Hi everyone, I'm Dr. April Jasper, Chief Optometric Editor of Optometric Management Magazine, and I am so excited to be here at booth F5056, which is LKC Technologies, and I am here at Vision Expo West in Las Vegas with Dr. Justin Schweitzer. Thank you, Dr. Schweitzer, for being here with us.
Yeah, I'm so excited. Thanks for having me. Looking forward to the conversation.
Absolutely. So what we're going to talk about today is ERG. And if you remember back, well, Justin's younger than me, but in my day, electroretinography was not necessarily something that was easy to do, nor was it something that any of us looked forward to doing. But things have completely changed, haven't they, Justin?
Yeah, totally different. I mean, we'll just show you right now. This is now what ERG looks like. It's a lot different than what we ever saw before
Oh, yeah.
and what we utilize on a day-to-day basis.
It is incredible. So we're going to talk a little bit about it. But before we start, I want Justin to tell you a little bit about himself. So tell us where you practice, a little bit about your practice.
Yeah, I practice at Vance Thompson Vision in Sioux Falls, South Dakota. It's a ODMD collaborative care practice, integrative care practice. And my main focus is on glaucoma and anterior segment disease. And so that's typically my day-to-day stuff. I work alongside a glaucoma specialist and take care of patients that a referring optometrist just asks for a second opinion on or preparation for surgery. And I always joke around like none of the patients that I see are mine. They're not.
Right.
They're all from my colleagues that are sending them in for us to see, and I love what I get to do on a daily basis.
I love that. So that means that they're not yours, they're ours, right?
Ours, exactly.
Yeah. So tell us a little bit about the RETeval and how in the world do you use that in a glaucoma practice?
Yeah, so I think of glaucoma like a large puzzle. There's a lot of pieces. And when we think about diagnostics to manage and treat glaucoma, we obviously have our visual field, we have our OCT, we think about pachymetry, I think about corneal hysteresis.
Right.
There's all those different pieces. And ERG fits in there as well because we're trying to put all these little pieces together to get to that main puzzle piece, which is diagnosing glaucoma accurately. And sometimes you need other pieces of the puzzle where you may have an OCT that you can't get an accurate measurement with because the patient has an abnormal optic nerve head, whether it be from disc drusen or whether it be from myopic degeneration or a long eye. And visual field testing, as we know, is not always accurate. And it's hard to take a visual field. I mean, you and I have taken them ourselves. They're not easy to do. And so you want other pieces of the puzzle, and really that's where ERG can fit in to help us piece that together.
So you bring up a good point, and that is that there are challenges in treating glaucoma. So, and even managing those patients. So what are some of the challenges that you face in managing your glaucoma patients?
We touched on it a little bit. I mean, if we're talking treatment, obviously compliance is a big issue.
Right.
But we're really here talking diagnostic challenges. And one of them is how do you get repeatable, accurate OCT measurements? There's patient bases that can be challenging in.
Sure.
Visual field testing can be challenging.
Yeah.
And so having those other pieces, whether it be corneal hysteresis or looking at ERG testing, which I know we're going to go through here in a little bit, can kind of be a tiebreaker in making decisions on should we treat this patient, should we just watch them closer, or do we need to be more aggressive with them?
So let's dive into that. How do you use the RETeval in practice?
Yeah, so I don't use it on every single glaucoma patient, but I use it on patients where I need that tiebreaker. I need more information. I have a patient where the OCT is not making a lot of sense to me, and I want to assess risk. So say it's an ocular hypertensive patient.
Right.
And I want to know, do I need to aggressively treat this patient? Do I need to start a drop, or can I just sit tight and watch them? And so I use the photopic negative response 3.4 hertz long protocol, which takes really 60 seconds an eye. And there's even a short protocol, which really takes about 30 seconds per eye. And so it's not a long test. It's easy to implement and use. And then I take that data and we look at a couple different things.
Yeah, so I want to know exactly that. I know people are listening, they're watching, and they're just like, okay, so you use the RETeval, you run that protocol, but then what are you looking for and what do you do with it?
Yeah, it's actually really easy once you use it a few times. There's two different things. There's what we call implicit time, which is a response time. How slow it is. If it's very slow, that means there's stress to the retinal ganglion cells. And we know that the retinal ganglion cells matter in glaucoma. We have that with our OCT measurement, but the beauty of this is we can detect stress earlier than we see damage with the retinal ganglion cell area. And then we look at the amplitude. A lower amplitude or a flatter amplitude equals damage to those cells. And so those two are the pieces that I'm looking at, speed and amplitude.
Okay, so now we've looked at speed and amplitude. How do you use those results to change what you're going to do and how you're going to manage these patients?
Yeah, so I'll just try to give you an example. So I mentioned earlier, glaucoma is like a large puzzle. There's a lot of pieces
Yes.
to it, right? So I may have an OCT that is maybe showing some early damage, but I have a clean visual field and a patient that has borderline intraocular pressures, thin corneas, and I'm trying to decide, do I bring that patient back in 6 months? Can I wait 9 months? Do I need a year? I get a test like this, the ERG, the implicit time is normal. The amplitude is normal or borderline. I feel very comfortable because there's not a lot of stress. That implicit time is normal. There's not a lot of stress to those cells. But I could probably stretch the visit out a little bit. I can wait a little bit longer.
Okay.
Where vice versa, if there's a lot of stress to those cells, I'm probably going to bring the patient back sooner, or I may even consider starting therapy for them.
Well, I think as we look at this, now you've got doctors that are saying, I love what I'm hearing. I love what you're telling me, but how am I going to fit this into my flow with my patients? So, what would you say to that question?
Yeah, well, everyone saw the size of it a second ago. It's not a big footprint. It doesn't take up a lot of area in your clinic.
Right?
And so, really, when I'm ready to order it, I just put it into my EHR. My technician comes in, and they do it. And I mention the time.
Wow.
They don't leave the exam chair. They sit in the exam chair. The patient doesn't go anywhere. 60 seconds per eye with that long protocol, and we move on. And I have the test results.
Incredible. So, you brought up your technicians and they run the test. How do you train them? How do you incorporate this in your process of really getting them to be comfortable doing this?
So it's interesting, we've used other technology, other ERG technology. This is the one that they adopted the quickest and told me, because for me, if my technicians don't like a technology, even if I love it, we typically won't adopt it. And so they
Yeah.
told me how much they liked the fact that they could keep a patient in the room, just reach for this, take it off the stand, walk into the room, do the test, and we're
Wow.
done. And so that's really what kind of got me involved in utilizing it more too, is just their love for it.
That's incredible. So we're here live. So let's see if there's any questions from the audience. Any questions, anyone? So Justin, is there anything else you would love to add or anything I forgot to ask you about the RETeval and how things are different now with ERG?
Yeah, the nice thing about this test too, and I didn't mention this, it can be done on a dilated pupil and undilated pupil, so you don't have to worry about that. For me, for example, my patients are typically dilated before I get into the room. Well,
Right.
I may not have ordered it yet, and so I
Uh,
don't have to bring the patient back. I can order it, at that point in time and still have it done. Or if I have a patient that's just in for a pressure check that I'm not going to dilate,
right.
but I want to get this because I want to follow a previous test that I did, because you can utilize this to follow patients as well to see if there's stress to the fibers that are occurring maybe at one visit versus the other. I'm able to order and utilize it in that way too. So dilated, undilated
And
is just fine.
what about light in the room, dark room, light room?
Yeah, it doesn't really matter. The biggest key with it is the sensor strips that are placed have to be lined up correctly. But I'll tell you, after just a few times of utilizing that, my technicians doing that, that's a very simple process.
Wow, that is so good to hear. Well, I appreciate all of you listening. And for all of those of you that are at home, thank you so much for spending time with Justin and I. But also, if you're here at Vision Expo West and you have not been by the booth, it's LKC Technologies and the booth number is 5056. So, Justin, thank you so much for being here with me.
Yes, thanks so much. It was a blast.